Okay, good afternoon, everyone. Today we're going to be doing the second part of the pharmacology lecture on the central nervous system. The next several slides, we're going to focus primarily on the neurotransmitters serotonin and dopamine and the effects that they have on various disorders in the body. So when we're going to be looking at the drugs, it's going to basically be how most of these drugs impact serotonin and dopamine to either elevate or decrease the effects of them. Now, when it comes to serotonin, most people think of this neurotransmitter as being one of the happy neurotransmitters or the happy neurotransmitter because it plays a role in mood regulation, but it does an awful lot of other functions in the body. When you look at serotonin, we have serotonin receptors not just in our central nervous system, but we also have it in the digestive tract. It's also found on red blood cells, or in the blood. It's involved with platelets. So lots of other effects in the body beyond just mood regulation. And the way that the different effects occur is it depends on where the serotonin is and which receptors it binds to in the body. So there are lots of different things that the various receptor types have on the body. So when you look at it, 5-HT refers to a serotonin receptor, but there's various isoforms that exist, and depending on which one that you stimulate will have a different effect. And so some may be involved with sleep, some may be involved with mood, others may be involved with digestion, depending on where they're located. Now this diagram it's a little mnemonic. This is how I remember things. It's just a little picture that sort of is easier for me to remember the basic effects that serotonin can have on the body. And so we know that serotonin is involved with mood regulation, but in addition to that, it also has these other effects. And so one of the things that serotonin has, the effects of serotonin in the body is involved with thermal regulation, or involved with adjusting the temperature of the body. And where this is sort of interesting is there are drugs now being used, certain antidepressant drugs that are being researched now for menopausal hot flashes, because serotonin, in addition to estrogen, can regulate temperature in the body. So if you stimulate those receptors, you're going to have a positive effect on the temperature of the body. Another thing that serotonin receptors have an influence on is digestion. And so if you overstimulate serotonin receptors in the gut and also in the central nervous system, it can induce nausea, vomiting, and diarrhea. So it can increase the motility of the smooth muscles in the gastrointestinal tract. And why this is important is that certain medications that we use to treat motion sickness or morning sickness will target serotonin receptors and inhibit those receptors. Other things, certain drugs that stimulate these receptors could have digestive or GI disturbances as a side effect associated with it. Now, in addition to the effects on mood and the effects on the central nervous system, one of the things that happens if you overstimulate certain serotonin receptors, you can induce hallucinations in the person and alter consciousness. And this is observed in people who take certain psychotropic plants like magic mushrooms or ayahuasca or LSD. They will stimulate these receptors and have this effect. But this could also happen with people taking pharmaceutical drugs. Let's say if they were overdosing, or if they ended up combining it with other drugs that affect serotonin, they might start having hallucinations as a side effect of these drugs. And finally, serotonin receptors are involved with circulation in the body. And so certain ones can have a constricting effect on various arteries or capillaries in the body, while other ones will have a dilating effect. Now, there is a very important thing that you should remember, and this is called the serotonin syndrome. And this is something that is a serious side effect of certain drugs that affect serotonin. And there's a concern that when you combine multiple drugs that affect serotonin, you could actually get an overdose of serotonin, which can cause the serotonin syndrome and this can be life-threatening. Now, people who experience this, the main thing that you'll see is that their mood will change. They may start acting a bit ecstatic. They may be hyper. They may start becoming a little delusional. They may overheat. They may start getting some nausea, vomiting, diarrhea associated with it. And there's also effects on various muscles, causing muscle twitching and hyperreflexia, as well as effects on the cardiovascular system, elevating blood pressure, and also having an effect on speeding up the heart rate. And so if someone overdosed on a drug, or if there's somebody who took like a recreational drug like ecstasy, which increases serotonin levels in the body, and they were to combine that with maybe an antidepressant, then someone might experience this serotonin syndrome. And so this is something that, unlike, for example, dopamine, there isn't really a dopamine syndrome that's life-threatening. Serotonin syndrome can be life-threatening when you start taking antidepressant drugs and combining them with other antidepressant drugs. And so just make note of this when we're discussing things. Now, on the topic of serotonin, a little bit of biochemistry to help you remember this stuff, a little integration in naturopathic medicine. Tryptophan is an amino acid that gets converted to 5-HTP. You can buy 5-HTP as a supplement, and in the presence of the cofactor vitamin B6, B6 with 5-HTP gets converted to serotonin. And serotonin will also then later be converted into melatonin as well. And so this pathway is used to make both serotonin and melatonin. 5-HTP is a supplement. Vitamin B6 is the cofactor involved with it. Now, if you were to look at 5-HTP, the supplement, you'd want to be careful giving this supplement to people if they were taking a MAO inhibitor or some kind of antidepressant that elevates serotonin, because it could cause serotonin syndrome if you took enough of the 5-HTP and if they're on a high dose of the drugs. And we'll talk about this a little bit more later on. So that's serotonin. Serotonin has some very interesting effects on the body. Now we'll discuss dopamine. Dopamine has a number of effects on the body. When I think of dopamine, I usually think of addictive substances, things like cocaine, crack, crystal meth, cigarettes, tobacco. So those substances, part of their addictive quality is related to the dopamine neurotransmitter. But dopamine is not all bad. There are some positive things that dopamine has in the body. It's all about having the right balance. When you look at dopamine, as we mentioned before, it's structurally related to epinephrine and norepinephrine in the body. So dopamine is a catecholamine, and you'll find these neurotransmitters in the central nervous system and also in the periphery to some degree as well. And there are many different receptors that are found in the body that for the dopamine receptors, and it's primarily involved with the reward mechanism, concentration. There's some GI effects that it has, some consciousness things. It's also involved with movement and has some hormonal effects, and we'll discuss that in a second. The main medical conditions that involve dopamine, either in excess or deficiency, are related to things like attention deficit disorder, or schizophrenia, or Parkinson's, also with drug addiction. And some of these, it may be a result of insufficient amounts of dopamine in the central nervous system. Schizophrenia can be influenced with higher amounts of dopamine. Parkinson's is low amounts of dopamine, and then drug dependence is related to your body releasing dopamine in response to cocaine or other types of addictive things. So this diagram that I'm displaying here, this is sort of a visual representation of the different effects that dopamine has in the body. Now we're going to start on the right-hand side. One of the things that happens if people take high amounts of dopamine is a little bit can make you happy and make you feel good, and this is related to the reward mechanism, but excess amounts of dopamine can make people a little delusional and even psychotic and start to hallucinate. So for example, someone who does a drug like cocaine, if they're taking high amounts of cocaine, they could become a bit delusional and psychotic if they're doing it. And so this can induce hallucinations. the reason why this is important to mention, there are certain drugs that elevate dopamine, could, if abused, cause people to become a bit manic or delusional, which could be a concern. Another thing that dopamine does is, like serotonin, it has an association with the digestive tract. And so dopamine, there are certain dopamine receptors that when stimulated will induce nausea and vomiting, and certain drugs that are used to as antiemetics will target certain dopamine receptors in the body. Now, another effect that dopamine has is with in the central nervous system is concentration. So people that are a little sluggish first thing in the morning, they need a cup of coffee to get going. That's one of the reasons why is that coffee does help release a little bit of dopamine. It helps make you a little bit more alert and focused, in addition to the other catecholamines. So taking substances that elevate dopamine, it doesn't at the right dose, it won't impair you. It actually makes your performance better. So just as an aside, people who do, there's a lot of white-collar people who do things like cocaine because it makes them more alert, makes them more focused, and doesn't impair their, well, it can impair their judgment, but it doesn't necessarily impair their ability to do certain tasks because it's basically enhances their concentration, their focus. One of the problems with things that mess around with dopamine is it does make you feel good. So if you've ever had, when you have that cup of coffee and it just makes everything seem right in the world, or people that are addicted to smoking, when they may feel miserable and then they have their cigarette, it makes them feel good. It's that reward mechanism. So it's involved with mood regulation and making people feel good. And so it has a positive effect when people go gambling and they win, the jackpot or playing poker or whatever it may be. That good feeling that's released is related to dopamine. Some people get this also from playing video games or from all sorts of things. Pornography can affect dopamine levels as well. And so it might make people feel good, but it does create that addiction as well, that people can get hooked on it. Now, finally, one of the things that dopamine is involved with in the substantia nigra, I believe it's pronounced that way, dopamine is involved with altering or has an effect on mood regulation. So a disease like Parkinson's has low amounts of dopamine, or some kind of, there's been destruction to the nerve, so dopamine isn't being manufactured and released properly. And so if you have too much dopamine, so if somebody was on a drug like crystal meth or cocaine and they had a really high dose, they might start getting involuntary movements. These are referred to as choreas, where they might have a twitch or start moving around or shaking or whatever it may be, and those are signs that dopamine levels are too high. So arms will start flailing or twitching in really, really high amounts, so large movements. That's why I've got that picture of a hand or an arm there moving a whole bunch. Now, if you suppress dopamine levels in the body, there's a few important things that occur with this. When you look on the left-hand side, people who experience Parkinson's disease, they have troubles moving and walking, and one of the things that they experience is they'll get a resting tremor, where because there's a lack of dopamine, they can't move the muscles properly, and they have a slight little shake just when they're sitting there doing nothing. So suppressing dopamine can develop tremors. That's one of the side effects. Another thing that dopamine does is it has an antagonistic relationship with prolactin in the body. So most of the things that we've discussed here are the effects of the neurotransmitters on the nervous system and concentration and mood and various things. In addition, it can affect prolactin levels in the pituitary gland. And so what ends up happening is when dopamine levels go up, prolactin levels go down. And so I put a bottle of milk as my picture for the prolactin, because prolactin is a hormone that's primarily responsible for stimulating breast tissue and getting women to grow or to produce milk. So women who aren't producing enough milk, they may be given a drug that helps to block dopamine at the pituitary gland, and that'll stimulate milk production. Uh, a couple other things that are worth mentioning is that substances that modulate dopamine receptors in the pituitary gland, like Vitex, the herb, which is a hormone regulator, helps to lower prolactin levels, or helps to balance prolactin levels anyways, and can be used for conditions like PMS. Um, with regards to the effects on prolactin, drugs that suppress dopamine can cause side effects like gynecomastia or milk production. Another thing is that prolactin is involved with, in men, for example, it's involved with libido. And so when men have sex after they ejaculate, they can no longer get an erection for a period of time, and that's related to the effects that prolactin levels go up, and it inhibits a lot of the libido and sex drive. And so drugs that suppress dopamine levels and elevate prolactin levels can cause reproductive disturbances in both men and women. In men, it can cause erectile dysfunction. In women, it may cause low libido, and in both people, it could cause a stimulation of breast tissue. So men might develop gynecomastia, while women might end up having increased milk production. And that could be a good thing or a bad thing, depending on what you're trying to treat. So that's a little overview of the effects of dopamine in the body. And in addition to that, just to give you a little bit of where this all fits in from a biochemical standpoint, phenylalanine and tyrosine are both amino acids in the body. Phenylalanine is an essential amino acid that can be used to make tyrosine. And then in the presence of using iron as a cofactor, tyrosine is converted to levodopa. And we'll talk about a little bit more about levodopa later on. It has been used as a drug, and it still is for Parkinson's. So iron is required to make levodopa, which then goes on in the presence of vitamin B6 to make dopamine. Now, dopamine is a catecholamine. It can then be converted in the presence of vitamin C to make norepinephrine, and then norepinephrine can be converted to make epinephrine. So these are all, or this is the pathway to make dopamine and norepinephrine in the body. Now, as an aside, one of the ways that I treat attention deficit disorder in children is I get their iron levels checked to see whether they're low or not. Because a lot of kids that have behavioral issues, often they're not eating the best diet. And if they're getting inadequate iron, there may not be enough iron to help promote the formation of dopamine. So they may experience low levels of dopamine. So some of the symptoms of an iron deficiency anemia, or even just iron deficiency, they may not even be anemic, but low iron levels, before becoming anemic, they may just experience headaches, low energy, poor concentration. Kids usually don't get the fatigue associated with it, so they may just get the difficulty focusing because they are not producing enough dopamine. So dealing with, for example, in adults, poor concentration, restless legs is another symptom associated with low levels of dopamine. So when it comes to treating your patients, working on the diet, removing food sensitivities, making sure they have adequate amounts of iron and B6 are all good strategies to do to help people with attention deficit disorder. So we've discussed the neurotransmitters serotonin and dopamine. What I want to talk about now is a little bit about how nerves move these neurotransmitters around in the body. Now, there are several monoamine transporters that are worth mentioning. Some target serotonin, some target norepinephrine, some target dopamine. And these are important to, after the nerve releases some kind of neurotransmitter to interact with the receptor, it has to be taken back up. And so these are used to reuptake or reabsorb the neurotransmitters so they can then later be stored in the storage vesicles. So there's another monoamine transporter called a vesicular monoamine transporter, which is responsible for taking the neurotransmitters and storing it within the cell. We'll talk about that in a second. So one of the ways that you can increase the effects of a corresponding neurotransmitter is by blocking the reuptake enzymes or transporters, and that leaves more of the neurotransmitter to interact with the receptors. Another way you can do it is you can increase the extracellular concentrations of the neurotransmitter so there's more of it around. And you can also specifically target the receptors, the serotonin and dopamine receptors on the target organ or cell. If you want to decrease the effects, there's a couple ways to do this. Is you can basically block the storage of the neurotransmitters by inhibiting the vesicular monoamine transporter, and then things like the catechol O-methyltransferase enzyme or the monoamine oxidase enzymes will break down those neurotransmitters. So that's a bit of a, if you found that confusing, we'll go into a little bit more detail in a second. So in general, various drugs like certain antidepressants will target the monoamine transporters. You have certain stimulant drugs will have enough, like cocaine and amphetamines will also target some of these various transporters. And then a drug that originally came from a herb called werwolfia, and the drug's called reserpine. It basically inhibits the storage of certain neurotransmitters involve the catecholamines like norepinephrine and dopamine, and it's used primarily to lower blood pressure, but it can also be used as an antipsychotic. Now this is kind of a random slide here. I'm just sort of throwing it in here just so you probably are covering antiemetics in another system, but just sort of a nice little mnemonic to help you remember. The main receptors that are targeted to help people who are suffering from motion sickness or side effects of chemotherapy like nausea and vomiting and diarrhea. Also, women who are pregnant and suffering from morning sickness. There are a few different strategies you can use to decrease vomiting. So the antiemetics can target basically muscarinic receptors, and so the class of drugs like the anticholinergics, like scopolamine, this is related to atropine. It can, if you take that, it basically shuts down digestive function and decreases nausea. There are drugs that act as a dopamine antagonist. So domperidone is used for two purposes. One, it can decrease nausea and vomiting in pregnant women. It can also be used for chemotherapy and a few other things. It might also increase lactation or promote milk production because by suppressing the dopamine, you increase the prolactin levels. Antihistamines like diphenhydramine, antihistamines are going to be found in drugs like Gravel, also certain medications used to treat allergies and motion sickness. They're all targeting these muscarinic receptors in the body and basically blocking them. And the side effects associated with this is you're going to have some sedation as well as a decrease in the nausea and vomiting. Certain receptors of serotonin, so the 5-HT receptors, 5-HT3 antagonists are other classes of drugs that are used to deal with nausea and vomiting, in particular associated with things like chemotherapy or other side effects of medication. And then also cannabinoids, so marijuana receptors or in the body like THC. So certain people will smoke marijuana if they're experiencing, let's say, nausea and vomiting from chemotherapy. Probably not a good idea if you're pregnant, but there definitely is a place for cannabinoids in medicine. So those are the 5 main receptors. I just like being able to see them all laid out with that. Just it helps me remember how everything fits together. That's how my brain helps to process things, using a little visual stuff. Now, just for fun, I think everyone here probably knows, certainly I mentioned it to you last year in herbal medicine, but ginger, it's a really great antiemetic herb that's used. You can use it safely during pregnancy. You can use it for chemotherapy, side effects of chemotherapy. And what's neat about this, if you've ever wondered how it works, is it basically targets 5-HT3 receptors, serotonin receptors. So it blocks certain types of serotonin receptors that are not involved with digestion and nausea and vomiting. And what's neat about this is these receptors, when I read about them, I'm like, oh, I know that those receptors are also involved with anxiety. And what's neat is if you stimulate these receptors, it can cause anxiety. And if you block these receptors, it can have an anxiolytic effect. And so what's neat is it appears that ginger does have some anxiolytic qualities, and it's not really the main traditional indication for it, but there are some clinical trials that show that it does have a beneficial effect on anxiety. And what I like about ginger is it's very safe, and it also has lots of other side benefits like reduces inflammation, helps with cancer, promotes digestion. So ginger, it's a great little root you can drink as a tea for not just to decrease decrease nausea, but also for anxiety. Now, migraines, you probably covered this somewhere else, but I want to just include it quickly in some of these slides, so it's a little bit of overlap, I suspect. When it comes to migraines, there are lots of different classes of drugs that can be used to treat migraine headaches. So basic analgesics like NSAIDs, the non-steroidal anti-inflammatory drugs, and acetaminophen, Tylenol, these can be used for most mild to moderate headaches. The opioids are not generally recommended, but they can be used if the pain is very severe and it's not responding to other things. When you're using things to control, as you know, with migraines, in addition to the headache and the pains, you're also going to get some nausea and vomiting with it. So often they'll use drugs that, like domperidone, or a drug like metoclopramide. Promide is a serotonin antagonist, and also certain antihistamines. So you've got three different types of drugs. One targets dopamine, another one targets serotonin, another one targets histamine, that can be used to decrease the nausea and vomiting with it. In addition to that, there are other drugs that can target certain serotonin receptors in the body, not involved with nausea and vomiting, but involved in vasoconstriction. So the tryptamines and ergotamine cause vasoconstriction that can help with the migraine headaches. There's a few other things that are worth mentioning. Tricyclic antidepressants, we'll talk about them later on, are sometimes used for migraines. So are certain drugs involved with like anti-epileptic drugs like valproic acid may be used to help control migraines. Also beta blockers and calcium channel blockers that we've already mentioned are used as well. So with migraines, there's a list of various ones. To focus in particular on the triptans, one of the first ones that came out was sumatriptan. The nice thing about the triptans is they all end in tryptan, so it's easy to remember them. And these are primarily used for migraines and also for cluster headaches. I've seen lots of patients on these drugs. The main effects that they have is they act as an agonist on certain serotonin receptors, the 1D, 1B subtypes. They also have an inhibitory effect on other receptors that are involved with trigeminal neurotransmission, and a bunch of other things. I don't actually fully understand how they work, but they do have some vasoconstricting effects that helps to relieve the headaches. Now, the side effects that are worth mentioning is because you have serotonin receptors also in the cardiovascular system and in other parts of the body, the main thing that you got to watch out for is it can cause a sensation of a tight chest, increased heart rate, hypertension. So someone who has risk of angina, probably not the best drug to give them. The other thing that's an unusual symptom that can occur with it is that people can get altered sensations with it, where they might feel warm, burning, or tingling sensations in their hands or feet or other parts of the body. So you want to be very careful. These aren't drugs that most people enjoy taking, and they should be used with caution. Anyone who has heart disease, I would stay away from them. Also pregnancy, because when you start messing around with serotonin, it's going to have an effect on uterine tone and all sorts of other things. And also asthma. So people who have difficulties breathing, little bit of bronchial constriction, these would be contraindicated. Now, ginger, and we've already mentioned it's good for nausea and vomiting. What's also really interesting is that ginger may play a role in helping to prevent migraine headaches. So I think this is really great because you can buy ginger over the counter. You can get it in capsule form. It's very safe, not a lot of side effects. And this study compared ginger with sumatriptan, the archetypal triptan drug, and they found it to be comparable. Basically said, if you look at the conclusion, the effectiveness of ginger powder in the treatment of common migraine attacks is statistically comparable to sumatriptan. So for me, I would at least offer this as an option to patients who have migraines. The way that I treat migraines is I always deal with food sensitivities first, and there's a couple of research studies that show that doing IgG food sensitivity testing and removing the foods that are coming up positive, that can help decrease the occurrence and the severity of migraines. So I might have them do that. I might work on various other things, including checking their iron levels, because sometimes people who are deficient in iron, that can trigger it if it's menstrual-induced migraines. And there's a few other things. So it's nice to be able to have options for patients. And removing food sensitivities, throwing a little ginger in, it's a nice little start for things. Now, still on the topic of migraines, ergot derivatives are worth mentioning. Ergotamine comes from the ergot fungus. Now, what's interesting about the ergot fungus is this was the plant that Albert Hofmann was working on, and he was basically extracting various ergot-like compounds from the fungus when he discovered lysergic acid diethylamide, so LSD. That's a potent hallucinogen. It's what a lot of the hippies were doing in the 60s. It changed the revolution. This is a very, very strong hallucinogenic substance that's found in the ergot fungus. Now, in addition to containing LSD, there's also other types of compounds that are structurally similar but target different serotonin receptors in the body. So, ergotamine, it does not cause hallucinations because it has a greater affinity for the receptors that are involved with vasoconstriction in the body. So it's similar to triptans, but has a different effect and also has some effect on other neurotransmitters, including epinephrine and dopamine in the body as well. Now, one of the main issues with ergotamine is that it has some pretty serious side effects, and this is not a drug that most people enjoy taking as well. It's worse than the triptans. It's not something you want to use long-term on a daily basis. You're not going to use it prophylactically for migraines. It's really reserved for severe cases. Because you've got serotonin receptors in your cardiovascular system and also in your gut, it's going to have some of those side effects where it can induce nausea and vomiting. And then with regards to the heart and respiration, it's going to have issue. It can be an issue. It can cause angina, elevated blood pressure, and one of the disturbing things it can do is cause peripheral ischemia. So if you're taking ergotamine long term, what it does, it causes vasoconstriction of the capillaries and arteries in the hands, and can basically cause if it's in severe cases, it can cause the digits to become basically, what's that word, ischemic, and they could start to rot and break off, and bad things would happen. So not really good to take a lot of this. In addition, it can cause some altered sensation and some uterine contractions, so you watch out with pregnancy again. Ergotamine is sometimes used in very severe postpartum hemorrhaging in order to get the uterus to contract. It's not uncommon to see it used in practice for that, and to stop bleeding. So now, just as a side note, what's interesting is if you look at some of the history books of some of the witch hunts that occurred in North America, there are some people who argue that the Salem witch hunts may have been sparked by the fact that it was a time period where there was a lot of rainy weather, and that the rye plant, which the ergot fungus grows on, wasn't being stored properly, so that it started getting moldy, and so people were inadvertently consuming significant amounts of the ergot fungus. And so some of these side effects might be people might start having altered sensations. They might start getting a lot of, might start feeling poison. Some people might start having their digits becoming ischemic and getting infected and falling off. And then because of the possible hallucinogenic effect, maybe people might start getting confused and being a bit psychotic, thinking they're seeing witches flying around. So whether that's true or not, it makes for a fun little story anyways. But the ergot fungus has a lot of good medicinal uses and has an interesting little story behind it as well. So now, just as an aside, another herb, there's a couple of herbs, migraine, herbs used to treat migraine. Feverfew and butterbur. Butterbur is a cousin of feverfew. They're similar in some ways. They have both been used to treat migraines. The precise mechanism I don't know, but I know that they appear to inhibit the release of serotonin from certain platelets, and they have an antagonist. Talk about a class of drugs called stimulants. This is a little review of how we can target some of these transporters in the body, and we'll go into this a little bit more in detail. Uh, Basically, the first condition we're going to discuss is attention deficit disorder, ADHD. So although this condition is multifactorial, researchers believe there's a significant genetic component to it, and probably dopamine and norepinephrine transporters and receptors are implicated on some level. So for some reason, there's just not quite enough dopamine in the body. And so people who suffer from this, they may gravitate towards drinking lots of coffee, maybe doing cocaine, or doing other sort of things that stimulates dopamine. Some of the symptoms is that they have difficulties focusing on things, so they tend to be a bit hyperactive, and they can't really focus on a particular task. And so in severe cases, it can become so inattentive that they can't actually focus on their relationship. So it could just be disruptive for their friends and family. They may not do very well at school because they can't sit still and focus on specific problems. There could be an emotional impairment where they might be more reactive and not able to control the emotions as well. So as we mentioned before, from a naturopathic perspective, I would be looking at ruling out an iron deficiency, looking at possibly doing an elimination diet to see if there's any food sensitivities that could be affecting the person. Also removing certain additives and preservatives like various yellow dyes, synthetic yellow dyes and blue dyes. They may have a negative effect on cognition. Omega-3s might have some benefit. Certainly there's no harm in doing them, so I might throw them in there. And then also using some nervines might have a nice calming effect. There may be a place for that depending on what's going on. So that's kind of gives you a little quick overview of some of the naturopathic things you might do. When it comes to pharmaceutical drugs, stimulants are the first line therapy against or for treating ADHD. And there are a few different ones that you could use for that. Now, in addition, you've got behavioral management. Some kind of counseling would be important to use as well. So some people might just need a little bit of talking to. Maybe some relaxation techniques would be good. I would say that without a doubt, one thing I didn't mention already was doing mindfulness-based meditation. I think that's going to naturally help your body become more attentive. Certainly, I think we can all be a little attention deficit at times, but when I practice mindfulness meditation on a regular basis, my brain gets more focused and calm, and I tend not to be skipping around and doing a million things. My thoughts are a little bit more calm. If I'm looking at Facebook, playing on the computer, doing that sort of stuff, trying to do too many things at once, then that's not healthy. Anyway, so stimulants are the main first-line drug for treating attention deficit disorder. There are two different classes of stimulants. You could have a norepinephrine dopamine reuptake inhibitor. So this would be some kind of drug that prevents the reuptake, or prevents the nerve from pulling the norepinephrine and dopamine back into the cell so it can be stored. So therefore, it's interacting with the receptors longer and sort of stimulating them, having that effect. Other things would be amphetamines or stimulants. So amphetamines, just like crystal meth, the same category. Crystal meth is a really terrible drug, but when used recreationally or smoked, or however people might take it, but it can be used for attention deficit disorder in a more controlled fashion. Now, in addition to the stimulants that are probably the most effective ways of managing ADHD, some of these other drugs that target norepinephrine, like a norepinephrine reuptake inhibitor, not as good as the stimulants, probably a little bit safer. Now, one thing to remember is that anything that's messing around with dopamine has the potential to be probably addictive, and also a lot of these substances that affect dopamine could become a street drug, or could be used or maybe used recreationally. So just keep that in mind when we're looking at this. Other drugs that are norepinephrine dopamine reuptake inhibitors, other classes of it, like bupropion, this is usually used as a smoking cessation, also as a atypical antidepressant. Bupropion's is something that's sometimes used as well. There are some other antidepressants like serotonin norepinephrine reuptake inhibitors that have been used. There's also some, remember when we were talking about the alpha adrenergic agonists, so clonidine, it has an effect on blood pressure, but it also can have an effect on mood. This is the substance that we talked about in the autonomic nervous system that ends up, it stimulates the adrenergic receptors in the central nervous system and inhibits the feedback mechanism, so less epinephrine or norepinephrine gets released, so it can help control some of the aggression and irritability and hyperactivity associated with the ADHD. So this is more symptom control, but it's not a main thing. And then finally, tricyclic antidepressants, antipsychotics. These are pretty strong drugs with a lot of side effects that aren't typically used very often anymore. But there's a whole slew of drugs that can be used. I think the most important thing to remember is the stimulants are going to be the first-line drugs. So methylphenidate. So this is Concerta, Ritalin, a couple of some of the brand names for it. This is going to be used to elevate dopamine levels and some norepinephrine in the body. So the main focus would be for ADHD, but some other indications might be something like narcolepsy, where you're having troubles staying awake, so you need to stimulate the person a little bit. It might also be used for chronic fatigue syndrome to boost energy. Now, something to consider is that these class of drugs, they work in a very similar mechanism that cocaine and amphetamine. So like cocaine and crystal meth, same sort of mechanism, very similar. Now the difference when you're doing crystal meth is you're probably smoking it, or if you're doing cocaine or crack, you're either snorting it or smoking it as well. And so you get a much shorter duration with a higher amplitude when you're injecting, smoking, snorting a substance. While if you're doing some kind of slow release oral dose, it's going to have a much broader plateau and less amplitude to the effects. So the effects will be not as pronounced and may last for hours, as opposed to if you're injecting a snorting where you have, it might only last for 5 or 10 minutes and the peak will be, much more intense. So so not only does it, I would say when it comes to taking a substance, the substance you're taking has an effect, but also how you take it has a significant effect. You can appreciate that if you were to drink, let's say, if you were to drink a beer on a full stomach versus an empty stomach, there's going to be a difference. If you were to take the alcohol out of the beer and inject it in your veins, it's going to have a completely different effect on the body. So although Ritalin does, or methylphenidate has some similarities to cocaine and crystal meth, the effect that it has on the body, what you experience when you take it as diagnosed by the doctor, is not the same at all. But it is interesting nonetheless. So some of the contraindications with this is that you don't want to combine these medications with other antidepressants. So monoamine oxidase inhibitors and tricyclic antidepressants, they have a lot of side effects. They're not common drugs that people take for depression, but if someone was on them for whatever reason, you wouldn't want to mix them up because it would just cause dangerously high levels of the norepinephrine and dopamine, and as a result, people could get like a hypertensive crisis with them. Finally, when it comes to methylphenidate, it can be used as a street drug. So sometimes university students will get this drug, ask their doctor to help them with their concentration because they are having trouble studying, and then they can sell it or crush it up and snort it like they would cocaine and have similar effects or a bit of a stronger effect that way. And so it's a kind of a controlled substance that they really do monitor who they give this to, and it's not really the first line drug for a lot of people because there's a potential for abuse for people to use this. Now, the amphetamines. So here's Breaking Bad. That was a fun TV show. Crystal meth was being, made illegally and sold on the streets. Very fun. If you've ever wondered if you ever want to make crystal meth, I don't really recommend it, but it's a pretty simple process. You could take ephedra, extract the ephedrine from it, and then with a very couple simple reactions, basically 2 reactions, you can make crystal meth from it. So it's not how they're making it on Breaking Bad, but very easy to get some sinus cold medication or the plant ephedrine and make it from that. Now, what's amazing with crystal meth is if you look at it from a recreational drug, look at the devastating effect that this drug has on people's lives. Like here's just some photographs. I don't know, I dug it up on the internet somewhere. Here's a woman 4 years after being on the medication. You can see how much it starts destroying the way they look. You can see they start losing weight. It destroys their teeth. They get this gaunt sort of hollow look to them. You can see how the fat in their cheekbones and their cheeks is being lost. One of the other things that people, when they do a lot of crystal meth, is they might start getting altered sensations, and one of the sensations, formication, which is the sensation of ants crawling on your skin. So they tend to end up picking at little lesions. So you often see people who do a lot of crystal meth have a lot of lesions on their face and their arms because they tend to scratch and pick at stuff. This guy, he had that's an awesome haircut, 2005. You would think that's like from like 1975, but anyways, he's got a good mullet there. On the right, got a haircut. You can see definitely lost some weight there. She lost some weight too. Shouldn't look too bad in the second picture, to be honest. But and this poor guy, yeah, just after a couple years, you can see they don't look good. So crystal meth, I don't think it's it's definitely not a recreational drug people should be experimenting with. It's extremely addictive, and that addictive quality is related to the effects that it has on dopamine. Now, when you use it as a prescription drug, some kind of amphetamine, it's going to be very, very different in that form. So it's going to be used primarily for ADHD, narcolepsy. It'll increase your alertness. You're going to feel, in high amounts, you're going to feel euphoric and you're going to have more energy. The goal is you don't really want your patients or patients in general getting high off of it. You just want to improve their concentration a little bit. So it's kind of like you might want them to have the equivalent of 1 cup of coffee, not 20 cups of coffee injected in their bloodstream, right? So that's the difference between crystal meth and doing something like an amphetamine from the pharmacy. Most of those capsules are going to be they're certainly formulating them away so they're slower release, so that they're harder to abuse. Some of them they don't allow them to be crushed up. Sometimes they'll add coloring to them, so it discourages people from snorting them. Otherwise, it sort of you get the blue glow coming out your nose. So the main mechanism for these, it's pretty complex, but the main thing is that it stimulates the release of dopamine out of the nerves and reverses the flow of the norepinephrine, dopamine, even some serotonin transporters. And it has a greater affinity for norepinephrine and dopamine, and a little bit for serotonin, but not significant amount compared to other drugs. So it's mostly going to have that strong stimulant effect. So if you look at those pictures that I showed you before of people who are addicted to them, your main side effects, if you were to take high amounts of it on a regular basis, would be weight loss. So you can see a lot of people's faces starts looking gaunt. People do a lot of crack. It's sort of they present the same way because crack has some similar qualities to it. People get some rapid tooth decay, and I'm assuming that's because of the effects that it has on the autonomic nervous system. It dries up the mouth, probably because it stimulates the sympathetic nervous system, and so all that, when you dry up the mouth, bacteria aren't washed away, and then it leads to rapid tooth decay. And also in high amounts, when people are doing it, it can alter their awareness and start making them a little bit psychotic. And if you think about it, medications that are used to treat schizophrenia basically block dopamine receptors and serotonin receptors, and substances that stimulate those receptors can cause psychosis or hallucinations. So when people are doing really high amounts, so they have an overdose, it can cause brain damage, can cause muscle breakdown, have really negative effects on mood, anxiety, paranoia. Certainly I've seen a few people on the street walking around acting a little bit aggressive, and I'm assuming they're on crystal meth or crack. Also in really high formication is that sensation of ants crawling on the skin, so they'll start picking at their skin and scabs and getting little skin lesions on themselves, self-induced. And then an overdose could cause death. So people taking too much cocaine or amphetamines could potentially have cardiac arrest, especially if it's older people doing it. Again, if you were to take these with other drugs that interact with the breakdown of dopamine and norepinephrine, then you're going to get yourself into trouble. So monoamine inhibitors, probably catechol-methyltransferase inhibitors, would also have a negative effect on these as well, and then tricyclic antidepressants. So the way that these amphetamines work is a couple mechanisms, and I'm sure it's even more complex than this, is one, it seems to increase the release of the dopamine and norepinephrine, and then it also inhibits the reuptake, or the reuptake basically means the pulling back of these amphetamines into the storage vessel, into the nerve. So if it blocks the transporter on the left-hand side, then it means that there's going to be more dopamine and epinephrine or norepinephrine around to interact with those receptors. And finally, it might actually internalize. It may take those transporters that are normally used to pull the dopamine back into the nerve and causes some of these dopamine transporters to be internalized back into the cell. So the overall effect is that you're just going to have lots of dopamine floating around and interacting with the receptors. So cocaine not really used anymore in the pharmaceutical realm as a prescription drug. Here's the coca plant. It's a picture I took in I think it's Colombia or Peru when I was down in the Amazon. Um, it's a very benign looking plant. There, you'll find people. So that's in a market in Peru. You can buy handfuls of coca leaf. It's very, very benign. It's a lot of people, a lot of the indigenous people, a lot of people chew it and just sort of get a mouthful. A gold museum in Bogota, Colombia. It's the best gold museum, and this is just some little artifacts that show that were found with pre-Columbian people who were using the coca leaf. So this dates back for thousands of years. Now it's interesting. I would say a few hundred years ago, there was a lot of famous people who enjoyed cocaine, and there was Mariani wine was infused with coca leaf, and His Holiness the Pope, he was a big proponent of it. So he, one of the popes, liked to do coke, which is kind of funny. Uh, Back in the old days, Coca-Cola was made from the coca leaf, and so there was a little bit more of a kickback then. Now they add caffeine, but back in the old days there was cocaine in it. Now, cocaine, it is used structurally. It can be used as a topical analgesic. I mentioned that before when we were talking about lidocaine and stuff. Um, and so they used to use there was cocaine toothache drops. So basically, cocaine was applied right to the gums to help relieve the pain. And so here's these cute little kids on the left there. They're all you can see they're working feverishly. They're building that little toy there because they're all high on cocaine. And so other famous people include Sigmund Freud. I remember reading a quote from him once that was basically saying he thought that cocaine was a miracle drug. And one of the things that he mentioned said, oh, it makes you feel euphoric. It has all these great benefits. And it's not addictive in the slightest bit. Uh, and then we got Rick James. There's some funny skits with Rick James on cocaine. The Rick Chappelle or the Dave Chappelle show. Um, Look at that outfit. It's ridiculous. So, obviously it must have been a little delusional when he picked out that outfit. So a lot of rock stars, music, and other musicians, artists, even Hollywood stars have done a lot of cocaine. It can, in small amounts, improve your performance, make you feel better. But the problem is it's very addictive, and people get hooked on it, and it costs a lot of money, and it can be very devastating in people's lives. What's interesting is when you look at the coca leaf is benign. Having chewed on it, and I would say the coca leaf is comparable to drinking tea or coffee in the indigenous people in South America. When you're chewing in that form, it's a very slow release. You don't get a major spike. It's a lot like drinking coffee, but with a little bit more of a dopamine effect to it. So it's a nice substance. What's interesting though is when you take cocaine and you combine it with some kind of alkalizing agent, this is how you form crack. And the difference between cocaine and crack is one proton difference. So one hydrogen makes a big difference. So cocaine on the left-hand side, because of that positive charge on it, on the nitrogen there, it's more water soluble, so it doesn't cross membranes as easily. Once you alkalize it, you pull that proton off. What ends up happening is it no longer has a charge. This means that it will actually diffuse through cell membranes, and it can cross the blood-brain barrier much easier now. And as a result, you can also, it becomes more heat stable, so it can be smoked without breaking down. So as a result, when people smoke crack, it goes instantly into the brain and has a devastating effect, or a very instant effect. I had one patient who told me, it's interesting, whenever I met people, when I worked at Parkdale, I had lots of patients who had crack addictions. And one of the things that there's often, most people with serious addictions usually were abused on some level, whether it's physical or sexual abuse growing up, and they start medicating with crack. Uh, but one guy who I knew, he used to do a lot of cocaine in the 80s, and he came from a rich, well-to-do family. And he was sort of saying, cocaine, we didn't do it too often, but we had it under control. I liked the party, and it made me feel more confident. And I asked him, were you ever sexually abused? He's like, no, I just enjoy doing cocaine. And then one day someone said, do you want to try some crack? And he said, sure, why not? And he did crack only once. And he said the experience was so intense and so high that from that point on, he's been battling with the addiction for 10 years. So cocaine's highly addictive and isn't something that I think people should mess around with. Coca leaf, I think, is benign. I really do. When you have an entire civilization doing it and chewing it, and it's, as a whole plant, it's you can't compare it to the isolated cocaine or especially crack. These guys are monsters that are destroy people's lives. Coca leaf, you could argue that it's very nutritional. It has lots of vitamins and minerals in it. It's used by the indigenous people. It helps with altitude sickness. It can help with fatigue. It can do all sorts of good things. These guys, you don't want to mess around with. It's just too dangerous, too high risk. You're probably going to really, really like it, and that's not a good thing. So most of the people I know, you do crack once, you could be hooked on it. Rob Ford, I probably shouldn't mention that, but it's now that he's passed away, it's not quite as much fun to make fun of him. But I don't know how much of a crack addiction he had. The fact that it usually causes a lot of weight loss and everything else. He was a very disturbed individual, and the fact that he was messing around with crack was probably not good for his career. Another example of it, here's a picture that I picked up off the internet of some woman smoking crack. You can see that very similar to people who are doing crystal meth. It just isn't good for you. So, don't do crack. And this here's a little risk. I was going to say risk benefit, but I wouldn't say it's risk benefit. Basically, what is the likelihood of a particular drug to cause physical dependence and physical harm? You look at heroin's at the top, cocaine, it's way up there as well. Interesting thing is barbiturates, they're way up there as well. Tobacco, pretty high up there. It's neat seeing that. LSD and ecstasy, they're pretty low. Cannabis is also pretty low. It does cause some dependence, but not too much physical harm. Alcohol and benzos, barbiturates, a lot of other drugs, amphetamines, they're much more dangerous on a relative scale compared to LSD and cannabis and things like that. So how does cocaine work? It comes from the coca plant. The main effects it's going to have, and it's used by indigenous people, more of the coca plant, not so much cocaine, would be it's an appetite suppressant, helps with fatigue, altitude sickness, and you can also apply it locally as an anesthetic. Now, from what I've read, there's a good book called Wade Davis. Remember when I was talking about the guy who makes investigated the zombies? He has a great book called The One River. Highly recommend if you're into ethnobotany and the Amazon stuff. And in his book I was reading that talks about how the coca leaf and how it was used to make Coca-Cola. Apparently in his book, and I don't know if it's true or not, but Coca-Cola still contains the coca leaf. It's like the active ingredient, but they've removed the cocaine from it for obvious reasons. And that cocaine is then sold to drug companies so they can modify it to make various, probably they're using it as a precursor to make other drugs or topical analgesics, topical painkillers and things like that. So the mechanism of action of cocaine is that it acts as sympathomimetic primarily. It blocks norepinephrine transporters, and it has a huge effect on increasing primarily dopamine and norepinephrine, a little bit like the amphetamines there. Serotonin might be affected a little bit, but it's not the predominant effects associated with it. So again, a lot like what we saw before, where basically blocks the reuptake of the cocaine so that there's more of the, or blocks the reuptake of the dopamine and norepinephrine, so they're around to stimulate the receptors more. So probably the effects that it's going to have is you're going to feel euphoric, you're going to have more energy, going to increase your self-confidence, a little bit more rapid thoughts, better focus, would be some of the things that it might do. And as I mentioned before, cocaine versus crack. Crack's a completely different monster altogether. It's not water soluble. It's a much greater high. So I would imagine that if you're doing something like chewing on a coca leaf, you're going to have a little bit of a slight little amplitude over like an 8-hour period. You do cocaine, you're snorting it, you're going to get a pretty big bump there that lasts for, I don't know, I'm assuming under an hour. You do something like crack, you're going to have a major bump that the duration may only be a few minutes. And from what patients who I've had who've done cocaine, they said there's nothing that they've ever experienced that comes close to the way they feel doing it. They say you just feel so amazing that you're always chasing that high again. And the scary thing about drugs that start messing around how you feel is I always worry about, I would never want to do something like crack, because if the best thing you've ever experienced is maybe a really good meal or sex or traveling or whatever, and now you suddenly have experienced something that's 1,000 times better, then that means normal day-to-day life is just going to seem really blah in comparison, and everything's all relative. So when you start messing with things that make you feel really good, then things that used to make you feel good are going to not give you the same level of pleasure, and it's going to drive you into depression. So a lot of people who have done recreational drugs, whether it's cocaine or ecstasy or whatever, I think it can sometimes drive people into depressive states. So we've talked about the stimulants, some recreational drugs that people use and have some issues. In the context of, we'll talk about some hallucinogenic substances as well. And so a lot of psychedelic substances are interacting with both dopamine and serotonin receptors. So things like magic mushrooms, ergot, so LSD, peyote, ayahuasca, they all have an effect on these receptors. And in shamanistic culture and other sort of cultures, they do have the ability to induce a mystic experience and change the way that people look at things. Having done ayahuasca, it was a very positive experience for me. It's terrifying, it was scary. In the context of doing it with a shaman, I think it was a really positive experience. There's a lot of negative that can happen with these as well, is that there are people, sometimes high school kids, who do mess around with these substances. They don't have a shaman or a guide to help them with it. It's not really done in a certain setting. I think what happens is it can open their minds up to things they're not ready to see, and can drive them into a severe depression. You know, if you suddenly become aware that everyone you love is going to one day die, that may be too much for certain people. In addition to that, some people are predisposed to schizophrenia or other kind of mental health disorders. It could get stimulated or induced by one of these experiences. People sometimes will go psychotic when they're on these substances, and as a result, it could trigger schizophrenia. And I've heard that happening to people before. So I'm certainly, having done these with shamans in the having done ayahuasca with shamans in the Amazon, I can say it was a very terrifying experience. It was a very positive one. It helped me sort of see the world differently. I enjoyed it, but at the same time, you get the wrong shaman, someone doesn't know what they're doing, deaths have occurred with people doing these things. So there are risks associated with it. The way that a lot of these guys work is they work primarily on serotonin and dopamine. Other hallucinogenic substances could target opiate receptors, so something like diviner sage. It doesn't work on the serotonin and dopamine. It's completely unrelated and has a completely different effect on the consciousness. And so people who are taking a lot of opiates for pain medication, they may become delusional or start hallucinating. That's because of the opiate receptors. And also anticholinergic or muscarinic receptors. There are certain ones in the body that are involved with consciousness. So people taking devil's trumpet or belladonna, they've been used in witchcraft and are associated with certain shamans, but they're kind of dangerous. So Many of the indole compounds, LSD, magic mushrooms, peyote, ergotamine, ayahuasca, they're all going to have a similar effect because they're all going to target serotonin receptors and dopamine to some degree. There will be some variations for sure. I think if you were to ask someone who's tried all of them, they would probably tell you that there is a similarity between them, but they are very, very different. The effects are very different, but yet similar. Compared to if someone were to do something that stimulates an opiate or an anticholinergic receptor, would be a completely different, you'd be on a totally different planet, totally different universe for that matter. There's LSD, there's, I think that's in psilocybin, magic mushrooms. Uh, Here's an example. This isn't peyote, but this is kind of the Peruvian equivalent of peyote. It's San Pedro's cactus. You can buy these at nurseries in North America. It's an ornamental plant. Um, you can, Richter's Herb sells it. I've had a couple of these plants over the years. They're quite pretty and they grow really tall and they fall over because um, that's what they do. They're not as pretty then. Here is in a Peruvian market. Someone's cut them up and has them for sale for people to buy. Um, it's used more on the Pacific side of the Andes in Peru, and it contains mescaline, the same active ingredient in peyote. Very different. It's not used in the same areas where they use ayahuasca. It's on the other side of the mountains. This is a piece of artwork done by Hueco tribe in Mexico, so in the northern part of Mexico, where the peyote tribes are. This is sort of the artwork they create using yarn that sort of symbolizes what they're seeing when they're taking peyote. And I think that I've never done peyote. I think it'd be interesting if I could find a shaman who's familiar with it. It would be interesting to do it in that sort of culture. Um, there's a lot of neat books. Teachings of Don Juan. He was an archaeologist who went down to Mexico and studied with a shaman called Don Juan, and they're written by Carlos Castaneda. They're kind of these new age psychedelic books from the 60s, but they're really neat. I think there's some neat aspects of shamanism, and they're definitely worth reading to get a neat perspective. I don't know if I believe everything in it, but it's kind of fun. They're fun books to read. There's another drug called Yopo, and this is a tool from Colombia, and that's used to grind up the seeds, and then it's blown into the nose, and it contains dimethyltryptophan, the same active ingredient in ayahuasca. And this is a tool that's used to blow up the nose. Here's ayahuasca, another psychotropic plant being brewed in the Amazon. These are the two plants that are in ayahuasca. Chacruna is on the right, and then the ayahuasca vine is on the left. And what's interesting about this is the plant on the left contains a monoamine oxidase inhibitor that helps the plant on the right that contains dimethyltryptophan be absorbed into the body. Here's an indigenous person. When I go down and when I've gone down into an ayahuasca, I haven't done it in a long time now, and now that I have a kid, I won't be doing it for, I don't know when I'll do it, if I'll ever do it again, but part of his culture, people do it on a regular basis. He's done it lots of times, and it's not a fun drug. It's kind of like doing yoga down there. Here's a shaman in the Amazon. They don't quite look like what you'd expect them to. This is Maloka where it's done. Here's artwork. This is yarn work, also done similar to what you see with the peyote artwork, but this is done by the Shipibo tribes in the Amazon. Now, one other recreational drug I'll mention, MDMA, another thing I've never tried. It'd be interesting too. There is a lot of research, there was some research being done with ecstasy or MDMA for helping people with post-traumatic stress disorder, anxiety disorders, issues with intimacy. I think there's potential for these substances to be used in a clinical setting to help people. Right now it's illegal and it's only really used as a recreational drug. One of the issues though with most recreational drugs is a lot of the time, if you were to buy this, apparently that you're not just getting MDMA, they usually cut it with other stimulants and it could be amphetamines. So pure MDMA, it works primarily on serotonin receptors and inhibits the reuptake of it, and also releases helps to stimulate the release of serotonin from the neurons. and may also act as an agonist for serotonin receptors in the body. So it basically helps to cause a release of oxytocin. If you think about what oxytocin is, it's like the snuggling hormone. So when you cuddle with or hug or with babies or boyfriends or whoever, you feel nice and warm and cuddly inside. So it's probably a nice thing. The main effects that it has is it causes euphoria, so it makes people feel really good, decreases anxiety, but it can also stimulate anxiety as well. Makes people more socially intimate. So if you've ever been around, I've been around people who've done it, and they're very, very touchy and they're very friendly and very happy. They're quite lovely people to be around, and very complimentary. I've noticed. Also, there's altered perception, so things might have a little bit of a enhancement in the shapes or colors or whatever visual sort of changes. So sounds pretty appealing, but I've never had the opportunity to try it. The fact that it's illegal makes it kind of if it were legal, I would try it. Because it's illegal, I kind of don't really want to mess around with some synthetic compound that's made in some guy's basement. So now the thing is, it's actually pretty easy to make ecstasy. So saffron, we talked about in herbal medicine last year. It basically comes from sassafras, and sassafras grows wild, and you can find it in Hyde Park in Toronto. It's a tree that's in the same family as cinnamon. It's very aromatic, and it has this saffron compound. This is a compound that used to be in the original root beer, but it was removed because it causes liver cancer. But if you take saffron and you do an extraction, it's a very simple, probably a 5 or 6 step reaction to make ecstasy or MDMA from it. And so you don't have to be a chemist to make it. Simple stuff. So one of the issues with ecstasy or MDMA, if you take excess amounts, or if you were to combine it with an antidepressant drug, monoamine oxidase inhibitor, or SSRI, you could cause serotonin syndrome. And if you think about what we described before, if you overstimulate serotonin receptors, you're going to get, person's going to feel euphoric at first, and they're going to become delusional, a little bit psychotic. They might start to overheat. They might start sort of having uncontrolled muscle movements, and it could lead to dehydration, overheating, and possibly death. So long-term use has been shown that it's related to depression. So if someone was going to raves every weekend and taking ecstasy, they're doing this for a year or two, eventually what happens is your serotonin receptors get down-regulated. So when you stop doing the drug, you just have less serotonin, so you have less of those receptors around to make you feel happy. Also, it's a neurotoxin. I think anything that overstimulates the nervous system, even things like ayahuasca or things like cocaine, ecstasy, crystal meth, when you're stimulating the nervous system, it's probably you're getting free radicals are being created as a byproduct because of all this extra mitochondrial activity, and then you're probably going to have some destruction of some of the nerves. So long term, it could make you a bit dumb and impair memories and cognition. Okay, so I'm going to take a quick little break here, and then I'll see if I can pause this, and then I'll come back in a few minutes, okay? Okay, so I'm back from my break. I had to do a little wardrobe change because I was playing with my daughter and she got food all over my shirt, so I'm wearing a different shirt in case you're wondering what happened. Okay, so we've got a few more sections we want to get through. We're going to do antidepressants, antipsychotics, and a little bit on Parkinson's and movement disorders. So when it comes to the pharmacology of antidepressant, there are different classes of antidepressants out there, and depending on which type of neurotransmitter they target, you're going to have slightly different effects and side effects associated with it. So the main objectives, we're going to talk about the monoamine hypothesis of depression. We'll talk about the major classification of antidepressants and some of the mood stabilizers. and discuss the mechanisms of action, side effects, and potential for interactions as well. Symptoms of major depression. So people who suffer, everyone kind of gets the blues once in a while. This certainly right now in the middle of January, the weather's been very gray. Everyone's feeling a little bit blah. But when you have major depression, the symptoms associated with it are going to be alterations in sleep, changes in appetite, depressed mood, loss of interest in things. So just things don't make you happy anymore. You're going to feel tired. You may get some anxiety or agitation associated with it. Difficulty with concentration and performing various tasks at school or work may be affected. People's confidence or self-confidence will probably go down, and they may get even thoughts of suicidal ideations or thoughts of suicide and ideation. So there's a DSM-4 criteria. I think actually now they have a DSM-5 criteria for it that you have to look at. I would say psychiatrists and a lot of research have a hypothesis called the monoamine hypothesis of depression, where it's the belief that depression is a result of insufficient amounts of various neurotransmitters, primarily dopamine, primary serotonin, but also dopamine and norepinephrine as well. People who are experiencing manic episodes, this is usually a result of too much dopamine or norepinephrine. We're going to go through the main class of antidepressants, not necessarily, well, we're going to go through them. I can't remember which order I put them in, so we'll discuss it in a second. But there's a few different ones. The first groups that came out were the tricyclic antidepressants. And then I would say the selective serotonin reuptake inhibitors were the next group that became most popular. These are drugs like Prozac, for example, that kind of revolutionized the antidepressants because there's a lot less side effects associated with them. And then after that, there's other ones that were affecting not just serotonin, but norepinephrine or dopamine as well. And then there's a few other classes we'll discuss. So when it comes to depression, the selective serotonin reuptake inhibitors are the first-line therapy, with another group called the serotonin norepinephrine reuptake inhibitor, a slightly newer class of drugs, are also the first choice. So basically, targeting serotonin is going to be the main objective of the drugs. And then there are some other ones that target norepinephrine as a secondary neurotransmitter. There are drugs called norepinephrine dopamine reuptake inhibitors that don't actually affect serotonin at all, but rather just norepinephrine and dopamine. These are often used for depression, but also as a smoking cessation aid. And we've already mentioned bupropion, which, depending on whether it's being marketed for smoking or whether it's being marketed as an antidepressant, will have the name Wellbutrin or Zyban. Look how many prescriptions of these various drugs were prescribed in 2006. So that was about 10 years ago. And I would say it's probably even worse now. The main thing you'll notice here is that selective serotonin reuptake inhibitors are the most common ones that were prescribed. The SNRIs You see some of those prescriptions, one in pink there. Um, and then bupropion, some of the other uh, retrazepine and some of the tricyclic antidepressants were also used. So a lot of people are on these drugs. And I think it's unfortunate that our society in North America, so many people are this unhappy, considering we're probably one of the wealthiest. I mean, the U.S. is one of the wealthiest nations in the world, and people still not happy. So money doesn't always buy you happiness. So um, now, in general, with most of these antidepressants, a few things to remember is that you might get some immediate effects when you start them, but it takes about 6 weeks before you get the full benefits of it. But the interesting thing is some of the side effects will start immediately. So you may feel bad from the side effects, but you won't necessarily feel happier right away, unless it's a placebo. Now, uh, antidepressants don't work for everyone. There is about a 30% non-responders effect to it. Uh, Also, it's worth mentioning that the placebo response rate for antidepressants is really high. So if you take a placebo, and I don't remember the exact numbers, and I think it depends on the type of antidepressant, but some studies, well, I know in general, placebo will get you at least 40 or 50% response rate, depending on the study, and probably the antidepressants are going to get you maybe 60 to 70%. So they do work better than placebo, but if you could get pretty much half the people who are on antidepressants, they responded to a placebo that had no side effects, wouldn't that be a better treatment solution? I think so. So I think this is an important thing for natural medicine. If people respond that well to placebo, why don't you give them some herbs and some natural supplements and some vitamins? And even if it was just placebo, which I don't think it is in most cases, at least you're not causing the side effects. When we're talking about the different classes of antidepressants, the side effect profile will depend on the class. So if the drugs are targeting serotonin or dopamine, um, you're going to get a different side effects associated with it. Most of the time when it comes to antidepressants, you need to take them for at least 6 months before um, the doctors will reevaluate whether they're helping or not. And then finally, when it comes to antidepressants, a little bit like the anti-epileptic drugs, you don't want to discontinue these abruptly. Um, you want to wean somebody off them. So if they're on a higher dose, you take that dose, you divide it in half or divide it into a 3/4, do it for a week, drop it back down to half, then do a quarter. Do it gradually over about a month. Some people who discontinue it abruptly, they could get seizures, they could black out, lots of negative things can happen. Now, the reuptake inhibitors, these drugs work by similar mechanism. So here, for example, is our nerve. We've got in green is the serotonin. The serotonin gets released into the synaptic junction, and then it binds to the serotonin receptor, making someone happy. And then what ends up happening is the serotonin has to get back into the nerve to be stored. So these transporters basically bring it back into the nerve. And if you block those transporters, then there's going to be more serotonin to interact with the receptor. So tricyclic antidepressants were the first class of antidepressants to come out. And I don't know exactly when they came out, but probably in the 50s or 60s, I'm guessing. One of the first drugs is amitriptyline, but there's other ones like nortriptyline. A lot of the tricyclic antidepressants will end in triptyline or in amine. And so it's just a simple way to help you remember them. Now, the main indications for these historically were for depression. We don't use them as a first-line drug for depression now, but they are sometimes used for things like neuropathic pains, sometimes for migraines, prophylactics treatment. I've known some people being given certain classes of tricyclic antidepressants to help with anxiety and sleep as well. And so some of these have become more common in just the last few years, but in general, most people aren't being given this for depression. The main reason why is that they're not selective for serotonin and norepinephrine, they're about the same size, and then dopamine to a lesser degree. So just remember, serotonin is in the front, norepinephrine is also in the front or close to, and the dopamine's at the back, so it's less significant there. And on the left-hand side, you can have side effects associated with the adrenergic, muscarinic, and histamine receptors. So what are those side effects? You should be able to deduce these. I don't remember all the side effects for drugs. I kind of just have a rough idea based on how they're working. So when I'm thinking of muscarinic receptors, if you're blocking those, you're going to have some fusion. So think about when people take too much belladonna or scopolamine or devil's trumpet, it can cause hallucinations in high amounts, dry mouth, constipation, increased heart rate. If you're messing around with the alpha receptors, you could have some effects on blood pressure, so lowering blood pressure, making someone feel sluggish. The histamine receptors, when you're targeting those, is going to have, or blocking those, is going to make you sleepy. And some other things that are going to happen is, like a lot of the antidepressants, weight gain is very common with them. Also, there's a risk of increasing seizures. So when you're potentially affecting dopamine levels, some of the other neurotransmitters, that could increase the risk of seizures. Also, there could be sexual dysfunction for a number of reasons. And sexual dysfunction is not uncommon to see with a lot of these antidepressants because of serotonin does have some involvement in reproductive as well. In overdose, one of the things with tricyclic antidepressants, if you wanted to commit suicide, you could take a bottle of tricyclic antidepressants and take the whole bottle, and you could have an overdose that can cause death. And so the main symptoms if you were to overdose is you're going to have an elevation of blood pressure, increase in heart rate, arrhythmias, convulsions, and possibly death. So if you were to take a bottle of serotonin reuptake inhibitors or selective serotonin reuptake inhibitors, you're probably not going to overdose and die from it. It might feel wonky, but the newer classes tend not to have death as a side effect with overdose. And so with people who are suffer from major depression, you don't always want to give them pills that they could use to commit suicide because some of them already have suicidal ideation. So, so that's one of the main reasons why tricyclic antidepressants aren't used. One, yes, they do work for depression, but two, they have a lot of side effects that people don't like, and three, you can overdose and die with them. Another issue that has occurred with MAO inhibitors or with tricyclic antidepressants is that when you combine them with other medications, there can be some serious interactions that occur. So monoamine oxidase inhibitors, not commonly used as antidepressants anymore. They have been used for other diseases like Parkinson's. Some herbs have some MAO activity. So if you were to combine something like passion flower, which has a MAO inhibitor in it, with someone who's taken a tricyclic antidepressant, there's potential for interaction there. So you want to have a little bit of a washout period before you combine these. Also, if somebody was on tricyclic antidepressants and they're doing street drugs, whether that's cocaine, amphetamines, ecstasy, that could be a real serious issue and it could cause serotonin syndrome. Also, people who are taking an anticholinergic or an antihistamine medication for some other unrelated condition, so maybe for seasonal allergies or taking for motion sickness, there's a potential for them to interact and increase the effects of one another. So from a naturopathic perspective, if someone's on a tricyclic antidepressant, watch out for those MAO inhibitors. Like I know rhodiola has a monoamine oxidase inhibiting effect. I know that harmaline in passion flower does. Nervines will add to the sedative effect. And also St. John's wort, because it's an antidepressant itself, will potentiate the action here. Now, another group of antidepressants that aren't commonly used are the MAO inhibitors. And remember, we talked about these in the first lecture. Monoamine oxidase enzyme is used primarily to break down or inactivate serotonin, epinephrine, and dopamine. There are a couple different isoforms or isozymes of this enzyme. MAO-A metabolizes primarily or metabolizes norepinephrine, dopamine, serotonin. MAO-B metabolizes primarily dopamine. And so that enzyme there is sometimes MAO inhibitors that target MAO-B are sometimes used for Parkinson's disease, and we'll talk about that later on. So MAO inhibitor drugs, they can be used for depression, but because they're not specific and they target lots of different neurotransmitters, there's lots of different side effects associated with it. So you're going to see some general stimulation. You're going to see some general stimulation, so it's going to cause some sleep issues and restlessness. It could cause digestive issues in people. It can also cause low blood pressure and dizziness, and also some anticholinergic effects like dry mouth and blurry vision. In general, when they're recommended, they try to achieve the dose that gives the maximum benefit with the least amount of side effects. So they're not necessarily going to start you on a dose that's going to cause adverse effects, but it's good for you to be able to deduce what can happen on these. And again, here's a little diagram. So the monoamine oxidase enzyme, it's in the liver, it's in the central nervous system, and it's primarily used to break down the neurotransmitters. Now, something with the MAO inhibitors that's worth mentioning is that because there are various things that interact with the monoamine oxidase enzyme that could be an issue. So if you're on this supplement, or if you're on this drug, a monoamine oxidase inhibitor, monoamine oxidase inhibitor, yeah, and you were to take some kind of precursor for dopamine, like the amino acid tyrosine, or L-dopa, which is made from tyrosine, or the same thing if you're on serotonin, melatonin, 5-HTP, tryptophan. Any of those types of substances, when combined with these drugs, could enhance those neurotransmitters and could become dangerous. Also, other antidepressant stimulants or hallucinogens, when combined with monoamine oxidase inhibitors, could cause problems. Now, typically when people put on a MAO inhibitor, what we usually do is discourage them from eating foods that are high in tyramine. Now, tyramine, which is illustrated on the right-hand side, it has sympathomimetic properties. It will interact with norepinephrine, it'll interact with the adrenergic receptors in the body and can have some serious effects on the cardiovascular system. And if you were to take a MAO inhibitor and eat foods that are high in tyramine, for example, fermented foods like red wine, also things like chocolate, avocado, certain types of cheeses, yeast products, soy products. If you get a big meal with all these tyramine-containing foods in it, normally what happens is the MAO enzyme in your gut will inhibit the tyramine so that it's not absorbed and won't have the effects on you. And that's one of the reasons why we have the monoamine oxidase enzyme in the gut, is to basically break down these neurologically active compounds in our diet. But if you're on this medication, it'll inhibit the enzymes in the gut and then allow the tyramine to enter into your body. When it enters into your body, it now has the potential to interact with the adrenergic receptors. So you could end up getting a hypertensive crisis if you were to combine lots of tyramine or any of these other substances and give it to someone who's on a monoamine oxidase inhibitor. Also, as an aside, vitamin B6 is depleted by the MAO inhibitors. So we talked about MAO inhibitors and tricyclic antidepressants. Now we're going to move on to the first class of antidepressants that were had relatively few side effects, and they were kind of considered to be like revolutionary when it came to the antidepressant drugs. I worked for the company who made Prozac, Eli Lilly, during my undergraduate, one of my co-op terms, and that was early 90s, and it was sort of the time when fluoxetine, which is Prozac, it was sort of the drug. They were making a lot of money from it because these other ones hadn't come out on the market yet, and so they kind of had exclusive rights, and they still had their patent at the time. And the reason why these were so popular is that they were selective in which neurotransmitters they targeted, and in particular, the selective serotonin reuptake inhibitors only affected serotonin, or primarily affected serotonin, maybe a little bit on some of the other ones, but mostly serotonin. And so fluoxetine, paroxetine, sertraline, citalopram, all these drugs are used primarily to treat depression. So it's the first line drugs for depression, with also the SNRI. So SSRI means serotonin, selective serotonin reuptake inhibitor. And then there's some other ones that target other neurotransmitters as well. So depression's the main thing. Now, anxiety is commonly treated with antidepressants now, as opposed to giving people benzodiazepines. And the reason for is that the benzos were far too addictive. So most mood disorders now, whether it's depression or anxiety, they'll give them antidepressant drugs. Another off-label indications that sometimes these antidepressants, these selective serotonin reuptake inhibitors are used for, is for menopausal hot flashes. If you remember before when we were discussing the effects of serotonin in the body, it does have an effect on thermal regulation. So, so there's another thing that it's used for. And the way that these guys work is it blocks the reuptake of serotonin so that more of it's around to interact with the receptors, but it also has some other effects where it affects the expression of certain receptors in the body. And yeah, it's kind of complicated. I don't even fully understand. I don't know if anyone does. But the main thing is affecting the reuptake, but there are other mechanisms as well. Things to watch out for: don't interact. Don't give selective serotonin reuptake inhibitors if people are on MAO inhibitors, if they're taking recreational drugs like MDMA, which targets serotonin. Excuse me, St. John's wort has an effect on serotonin. We'll talk about in a second. So it could interact and cause some problems. And also 5-HTP, which is a precursor for serotonin. It's unclear whether or not it's dangerous to combine them. Generally speaking, I would not combine 5-HTP with people who are taking those medications. It's possible that 5-HTP, supplementing it with a low dose of a SSRI might be beneficial, but right now I think pretty much everyone says just don't do it because we don't want to cause serotonin syndrome. As we described earlier on, serotonin syndrome is pretty scary and it can be life-threatening. So the main side effects associated with a lot of these antidepressants is going to be digestive issues. It may cause some sleep issues. Weight gain is not uncommon to see, and I don't even know if I mentioned there, weight gain is relaxed. Anyways, Effexor is what I call it. I can't even pronounce it. Effexor is a very common one that you see a lot of people taking. It's used for depression, anxiety. It's also used for certain pain issues like fibromyalgia as well. It's going to work primarily on serotonin and norepinephrine, and only a very, very, very slight effect on dopamine. So you're not going to have a major dopaminergic effect there. So it's mostly the serotonin. The effects or the side effects that you're going to see is going to be similar to what you see on the SSRIs, but the main difference is because it's involving norepinephrine, it's going to have a greater effect on elevating blood pressure. So if someone came in and they had high blood pressure and they were taking this medication, you might want to rule that out as a cause for their high blood pressure. Or if someone had high blood pressure, you may not necessarily want to start them on an SNRI. So again, first-line therapy for depression and anxiety, similar to SSRIs, but there is a little bit more of a norepinephrine involvement. That's going to cause a little bit more restlessness and elevated blood pressure. Norepinephrine dopamine reuptake inhibitors, the NDRIs. So here we're going to have a couple actions. One, because it's affecting norepinephrine's involved with mood regulation. You'll see some effects there. And now you're bringing in the dopamine. And because of the effects on dopamine, dopamine has a reward mechanism, so that's a little bit different effect on mood than you're going to get with the serotonin. Now, from what I've read, what's interesting about antidepressants, I probably should have mentioned earlier, is that even though in theory we think serotonin has this is considered to be the happy neurotransmitter and dopamine is the reward one, when you do a comparison of a lot of the antidepressants out there, there's very little difference in the efficacy of the various classes of antidepressants, regardless of whether it targets serotonin or norepinephrine or dopamine. They all kind of work for depression really well. And so even though in theory, the monoamine hypothesis theory, it's pretty complex. We don't even fully understand why these things make people happy. Certainly, I don't think people should be on antidepressants. I think there's the majority of people definitely don't need to be on these, but it's very interesting that it doesn't seem to matter which neurotransmitter they mess with. They all seem to have similar actions. Now, the norepinephrine dopamine reuptake inhibitors, we talked about these already. Bupropion, which elevates both dopamine and norepinephrine with very little effect on serotonin. There might be some, but very little. What's neat about this is, in addition to those effects, it may modulate nicotinic receptors to some degree as well. And so, because of its effect on dopamine, you could use, or it is used for smoking cessation, can be used for depression, usually as a second-line therapy, not the first-line therapy for depression. Can also be used as a second-line therapy for ADHD, neuropathies, might be beneficial with even Parkinson's because you're messing around with the dopamine levels, and dopamine is involved with all those conditions. Now, because it's involving dopamine, you'll notice that most of the drugs that are playing with dopamine, it increases the risk of seizures. And if you think about going back to the original diagram of the dopamine and the effects that it has, remember when we're talking about the movement stuff, we know that too little dopamine will cause Parkinson's disease and a resting tremor, and lots of dopamine will cause choreas or involuntary movements of the hands. And so if someone's susceptible to seizures and they're taking something with lots of dopamine, it might just hyperstimulate the movement and could induce seizures. I don't know what the mechanism, but that's kind of how I remember it. In addition, because it's affecting the norepinephrine and dopamine, these are act more as stimulants in the body. So the side effects associated with it is going to be even more restlessness. And because dopamine in excess can cause hallucinations, there is potential for there to be like psychotic episodes with it, especially when combined with other things that mess with dopamine, like someone was taking cocaine with it or something. The big selling point for, I would say, the NDRIs is, unlike the SSRIs that have sexual dysfunction as a part of the side effect profile, you don't get the sexual dysfunction because you're not messing with the serotonin. And because you're elevating dopamine, we know that too little dopamine, if you have elevated prolactin levels, it'll suppress dopamine. If you have increased dopamine, it actually acts as an aphrodisiac or as an increases libido in men. So things that increase dopamine will actually enhance sexual function in some cases, or at the very least won't have a negative effect. So too much serotonin can cause erectile dysfunction in men, but you don't see that with these NDRIs. So that's a pro. So if someone was on an antidepressant and it was affecting their sex life, you could always tell them, well, there are other antidepressants you can try, including the NDRIs like bupropion. So again, the main neurotransmitters, dopamine, norepinephrine, those are the two big ones that it's going to be targeting, the reuptake of those neurotransmitters. Serotonin to a very small degree. And also, just as a side note, is it may have a modulating or an antagonistic effect on the nicotinic receptors as well. So that's one of the reasons why it's a pretty good choice for people who are unsuccessful with smoking cessation. Now, this is sort of a weird little drug class on its own, the noradrenergic and specific serotonergic antidepressant, NASSA. So, retrazepine, this is just sort of one group that's all on its own. It's often used as a first-line drug for depression and also anxiety. It's similar in structure as many of the tricyclic antidepressants, but has a lot of different functions. It's primarily targeting the norepinephrine and has a modulating effect on some of the serotonin receptors. It might also have a little bit of a blockage effect on one of the histamine receptors. So the main side effects with retrazepine is you're going to have more sedation than you do with the SSRIs because of the effect involving the histamine. And as we know, antihistamines make people sleepy. So a drug that targets the histamine receptors is more likely to make you sleepy. The other thing that you're seeing is that you're getting weight gain with this, and it's worse than what you get with the other SSRIs. So because of its effects on one of the serotonin receptors, it increases appetite, makes people more hungry. So if somebody was underweight and they had trouble sleeping, then this would be a good drug for them. If they were overweight and didn't have a lot of drive, then that wouldn't be the best one for them. So finally, it does have less sexual dysfunction than the SSRIs, which is another selling point to it. So sometimes the advantage of the metrazapine is that people might take that as a sleep aid to help relieve anxiety, calm them down, and take it before bed. So people who had depression with trouble sleeping, it might be a good choice in that situation as well. Now, I'm going to throw a couple herbs in here just so you can understand how these guys work, because I think it's kind of fascinating. Indian tobacco, Lobelia inflata, it's used a lot for smoking cessation. There's research in animals that suggests it might actually help with amphetamine addiction or cocaine addiction, which I think is kind of neat. The way that it works is it basically modulates nicotinic receptors in the body and also inhibits the reuptake of dopamine and serotonin. And what's interesting is if you were to take Indian tobacco, it's not that it doesn't relieve the nicotine, um, the dopamine or the nicotine cravings when taken acutely. It's often recommended that before you quit smoking, to start taking it while you're smoking or while you're doing crystal meth or something like that. Because what it's shown in animal studies for crystal meth or for amphetamines is that it basically reduces the release of dopamine that occurs when people take amphetamines, or when rats take amphetamine anyways, assuming it's like humans. And so it means that if you're smoking, you don't get the same dopamine release, so there's less pleasure associated with it. Or with smoking, the same sort of thing. So if you look at the receptors that it's involving here, um, we've got it inhibits the reuptake of dopamine in general, has some effects on serotonin, and then it modulates these nicotine receptors in the body. And so it's not a bad thing to use for smoking cessation. I have used it, but the whole thing to remember is it's better to start people on it so that it kind of curbs the response from the nicotine while they're smoking, so it makes it a little bit easier later on to give it up because they're not getting the same enjoyment out of it. Now, another herb I want to talk about is St. John's wort. So from an evidence-based standpoint, St. John's wort's been shown to be effective for mild, moderate, and severe depression. And one of the things about St. John's wort that I like is that in many trials, it's been shown to be as effective as conventional antidepressants without the safety profile, or without the profile. for the glutamate or NMDA receptors. So it's a whole slew of things. So I think here you can see it's affecting the reuptake of serotonin, dopamine, norepinephrine, decreasing the expression of the beta receptors, and then also inhibiting the glutamate receptors and acting as a bit of an agonist for the GABA receptors. So St. John's wort, I don't use it a lot. There are some side effects with it. The main thing to remember about St. John's wort is you need to be taking it for about 4 or 5 weeks, just like the other antidepressants, to get the full benefit from it. My greatest concern with it is that, as you probably already know, St. John's wort, it basically induces certain cytochrome P450 enzymes, and that can increase the clearance of a number of drugs, ranging from certain drugs that have an effect on the central nervous system, like the benzodiazepines or levodopa, some of the anti-epileptic drugs, statin drugs for lowering cholesterol, certain drugs for HIV patients, and hormones. So lots of interactions. So if somebody was taking other drugs, I would just stay clear of it altogether. Other safety concerns that are worth mentioning is that it can cause increased risk of sunburns. And with people with bipolar or schizophrenia, I'd be very careful. I wouldn't actually recommend it to them or give it to them, because it could aggravate a manic episode. So best to stay clear of that. Another herb to mention really quickly, rose root. So rhodiola, a couple things with how it works. It's a great adaptogen. It's used to help with stress, increases energy. Can also be used for mild to moderate depression, some anxiety. And also help with some cognition as well. The main active ingredients in this appear to interact with the HPA axis and decrease cortisol levels, but they also act as mild monoamine oxidase inhibitors and catechol-methyltransferase inhibitors, and may have some modulating effect on some of the serotonin receptors as well. And there are some clinical trials showing benefits for depression. They're relatively, I don't think there's very many side effects. I actually would prefer to start with something like rhodiola over St. John's wort. One, because it's helping people cope with stresses, and that's a good thing. Two, there's not a lot of side effects. So even though I mentioned there's side effects associated with the monoamine oxidase inhibitors, these are very mild ones. They're not that good, so it has a very gentle effect, if any. So I haven't seen very many side effects at all associated with these. I would still be careful about taking them with other drugs that affect the central nervous system, just because there's the potential to interact. Fish oils. Fish oil shows benefit for a whole bunch of different conditions. You can read this. EPA might be a better antidepressant. There's some studies showing that it works as good as conventional antidepressants. Again, if I had someone come in with depression, I'd probably give them some fish oils. I'd give them probiotics. I didn't even mention that in the slide that has some antidepressant qualities. I give them maybe some adaptogens, whether it's rhodiola or some other type, because even ginseng has some antidepressant effects. Get them to exercise, which is another important antidepressant. Get them to eat better. Maybe give them 5-HTP. It's almost, I very rarely give people St. John's wort, but it is an option that I use. So that's the main drugs used for depression. When it comes to anxiety disorders, it's similar. The first line drugs here are going to be the SSRIs. So just like you see in the when you're treating depression. The second line therapies are going to be antidepressants like the tricyclics, NDRIs. Probably they're not used as much just because the norepinephrine and dopamine, they have a little bit more of a stimulatory effect. I could see that causing being more anxiety provoking. Benzodiazepines, they're not first line mainly because they have an addictive component to it. Buspirone is an interesting drug. We'll talk about that momentarily. It kind of modulates a few different receptors. And then the third line drugs would be for people with severe anxiety. You're going to be looking at anti-epileptic drugs and some atypical antipsychotics. We'll talk about that later on. You can just look at that. So here we have a partial agonist of the 5-HT1A receptor. Buspirone is the drug, and it's used primarily as in the treatment of generalized anxiety disorder. So it modulates the serotonin receptors involved with anxiety. It might have a bit of an antagonistic effect on certain dopamine receptors. So I don't know a lot about the drug. It's kind of an unusual class of drugs, but it is a commonly prescribed one for anxiety. Again, you want to watch. I don't recommend combining it with certain medications like MET inhibitors, and it's contraindicated with diabetes. I forget why that is. It has some, I think it elevates blood sugar for some reason. So we've talked about depression, we've talked about anxiety, and then we're going to talk about drugs used to treat people who suffer from psychotic episodes. So the main condition here would be schizophrenia, and also I would say bipolar. So, cover the learning objectives. We're going to talk about dopamine and its effect on schizophrenia. Also, we're going to distinguish between typical and atypical antipsychotics and discuss some of the mechanisms of action. Psychosis is just a mental state where your sense of perception of reality, cognition, and mood are disturbed. Now, when it comes to schizophrenia, there are a few different ways that people present themselves. Usually there is association defect, so the inability for people to think logically. So I know there's some people who are, what do they call them? I know one person, I'm convinced she has schizophrenia of some sort, but has never been diagnosed. And she believes that the world is flat, and she also doesn't believe in gravity, and she's always posting things on Facebook about, she's a flat earther, and so she constantly is posting all this stuff. And she's just completely illogical, and you know, her ideas are crazy. And maybe it's because she's schizophrenic. There's something wrong with her. I don't know what it is. But anyways, that would be one example. People are completely illogical and irrational. That would be one symptom. There's also the affect disturbances. So people don't show the appropriate emotional responses. One of my uncles is schizophrenic, and you know, it's like you see strange behavior. So if somebody accidentally hurts themselves, you know, badly, they might just like burst out laughing. You know, sometimes it's funny if a friend trips and hurts himself, you might laugh, but if someone really hurts themselves, you don't want to laugh. Or they might just kind of walk into a room and just burp and just kind of not realize how inappropriate that is to do that. Another one of the symptoms is ambivalence. So they can have mixed feelings, sort of a like love-hate relationship towards things. And then the final thing is an autistic sort of behavior, and autism where it's unable to relate to others or their environment. So they just seem incapable of holding a job down, maintaining interpersonal relationships. It's unfortunate. And so one of the things that's believed is that people who suffer from schizophrenia may have elevated amounts of dopamine in the system, and this dopamine is causing psychosis. And if you remember going back to this diagram here, remember this, because if someone has elevated dopamine, you're going to get things like psychotic episodes. That's what people with schizophrenia may be presenting with. They may not have the choreas and the emesis and the other things. And why this is important is that if you're giving antipsychotic treatments that are suppressing dopamine, then you got to think about what the side effects are going to be, and that's going to be the tremors and the elevation in prolactin that's going to cause sexual dysfunction and gynecomastia and a few other things we'll discuss in a second. Now, when it comes to schizophrenia, there's two main classes of symptoms that people get. There are the positive symptoms, which are things that they present with that is the average person doesn't have. So this is where we're talking about the hallucinations or behavioral disturbances that accompany people who have schizophrenia. And so they might see, you know, they might, a lot of people with schizophrenia, they have a lot of spiritual and religious sort of things associated with it. So often they think they're talking to God, or God's talking to them, or they, you know, they might have little weird behaviors that they might exhibit. Those would be the positive symptoms. The negative symptoms are when they don't present certain behaviors that they should see. So this is where they may have apathy, where they don't show any sort of feelings towards other people, or they have flattened emotions, where they something that should make them happy or sad or angry doesn't have any sort of effect with that. And then they withdraw from communities and become more of a hermit. So um, those are the main types of symptoms that what people will present with. There are two classes of antidepressants we're going to talk about. The typical antipsychotics, and then we'll talk about the atypical antipsychotics. And what we find is that the typical antipsychotics are beneficial for treating the positive symptoms, like hallucinations, um, but not used to treat the negative symptoms. And the newer meaning like decades ago, as opposed to, well, they're both decades ago, but they're more recent anyways. The atypical, they're second generation antipsychotics. Um, these had some benefit on the negative symptoms of schizophrenia as well. So here's a whole list of various ones that exist for the various typical and atypical antipsychotics. We're going to start with the typical antipsychotics first. These are the drugs that were developed first, and were probably some of the first ones used to treat schizophrenia. They're still used today. Remember when I told you the story about grandfather-in-law who ended up in the hospital, and they gave him a certain zopiclone drug that caused him to develop hallucinations. They give him haloperidol, a typical antipsychotic, which is used for schizophrenia to help relieve some of those psychotic symptoms that he's experiencing. Another example is haloperidol has been used when people do a drug overdose of something like magic mushrooms or LSD or peyote or other types of drugs that have like cause hallucinations. They'll often give people haloperidol or an antipsychotic drug to suppress those symptoms because it's pretty fast acting, and it sort of takes them off that quote unquote high that they're experiencing. So it's interesting that people, for example, shamans are a little crazy. So shamans who are doing psychotropic plants like ayahuasca or magic mushrooms or peyote, they're seeing these hallucinations are having. There's a fine line between that and schizophrenia, which is interesting. And I know a few people have had schizophrenia, and they're illogical at times, but sometimes they have a very interesting perspective on the way they look at things, and they sometimes have some really interesting insight into the world, but then other times they're totally way off. Anyway, so typical antipsychotics, haloperidol is one of the classic ones. And what it does is it basically acts as an antagonist for the dopamine, the D2 receptors in the body. And as a result, what ends up happening is in the central nervous system, it helps to suppress the hallucinations. But the other problem is that you get a lot of side effects related to the effects that it's going to have on dopamine in the when it's involved with movement disorders. So side effects associated with the typical antipsychotics is going to be significant extrapyramidal effects, and this refers to Parkinson's-like symptoms. So you're basically causing like a drug-induced Parkinson's that can cause a resting tremor. That's when you see people who are on these drugs, they often will have a bit of a resting tremor. Their hand just sort of vibrates. Also, because as we mentioned before, dopamine and prolactin have an antagonistic relationship with each other. Suppressing dopamine will lead to an elevation of prolactin. And that elevation of prolactin is going to cause reproductive disturbances, low libido, can also cause gynecomastia in both men, and then in women it could cause increase in lactation or breast tenderness. So lots of different things that can occur. I think I just discussed this. One of the side effects, easy to way to remember, it causes pseudo-pregnancy, where you get the galactorrhea, menstrual disturbances, sexual dysfunction, and that's all as a result of that prolactin. Another thing that can occur is in rare cases, it can cause neuroleptic malignant syndrome, which is very, very serious life or death syndrome that can occur with people taking these drugs. Oh, there it is. I forgot how to slide on it. And so the symptoms associated with it is muscle rigidity. So people they can't their muscles become really tight. They develop a fever, so it's almost like seems like an infection. Uh, Issues with the autonomic nervous system, causing an elevation of blood pressure, alterations in cardiac function, uh, can cause altered consciousness, and then elevation of the creatine kinase, probably because of the muscle breakdown, and also elevation of white blood cells. So not a good thing. It can occur with the second generation antipsychotics, but it's specifically connected with the typical antipsychotics. So the typical ones are the first generation. The atypical antipsychotics are second generation. And they can be used to treat hallucinations, but the benefit is that they have less of the side effects associated with the typical ones. The reason why this is unlike the typical antipsychotics that only target dopamine receptors, the atypical ones also target certain serotonin receptors in addition to the dopamine receptors, so it does it to both of them, so that you're reducing hallucinations by working on two receptors, so that way you can kind of reduce the antagonistic effect on dopamine, and as a result, you're going to have less of the Parkinson's and the hormonal disturbances, which is a positive thing. So, some of the interactions to watch out for. You don't want to give atypical antipsychotics to people who are taking SSRIs because they're both affecting serotonin, so there could be some issues with that. Alcohol is going to have a depressant effect. That's not going to be good. I'd watch out for certain herbs that have a sedating effect, like valerian or kava, because in addition, most of these medications, both the typical and atypical antipsychotics, have people are feeling sluggish, sleepy, and sedated, and so you've got to be careful combining that. So going again, mentioning the atypical antipsychotics, the main side effects associated with this, the main benefits is the fact that you have less extrapyramidal effects. So this is, you're going to have less of those Parkinson's symptoms, and also less side effects associated with the elevation of prolactin. So that's a positive thing. There are different drugs, and some of these have certain affinities for certain receptors more than other ones. When you look at some of the drugs, they also have certain side effects that are unique to certain classes. So clozapine has something called agranulocytosis, which is a disruption of certain blood cells. Because the atypical antipsychotics are less specific, one of the other things that you see is that there can be muscarinic, adrenergic, and more cholinergic effects in the body. So you might get dry mouth and constipation because of the anticholinergic effects. You may get low blood pressure. You could get more sedation, which isn't good. Seems to have an effect on seizures. It lowers the thresholds, and then again, you can get the neuroleptic malignant syndrome, but it's less common with the atypical ones. So that's schizophrenia. Now moving on to bipolar disorder. Bipolar disorder, it's a little bit like depression combined with aspects of schizophrenia. So the way you treat it is basically you have people, this formerly was called manic depressive. It basically means someone might be depressed for months and then they have a manic episode, which means they suddenly become, their moods become really elevated. They might become really, their self-confidence goes up. They don't need any sleep. They become a lot more talkative. They have lots of neat ideas. They might go and do some crazy stuff and have some, go gambling, or they might become sexually promiscuous and do a bunch of drugs. So often when people are in their manic period, it can be a lot of fun, to be perfectly honest with you. I've met a few people who suffer from it, and they're way more fun when they're manic than when they're depressed, I'll tell you that. And they're just sort of outdoing some little reckless behaviors. The problem is they end up getting themselves usually into trouble. And yeah, I won't go into any more detail there. The main first-line therapy when treating people with bipolar is giving them lithium. We'll talk about that because we haven't discussed that yet, and it's a very unusual sort of drug. Antipsychotics are often used for people with bipolar. It's going to be more useful for controlling the manic episodes and not so much for the depression. Also, certain anti-epileptic drugs are useful during the manic and the depressive period. So, lamotrigine, valproic acid, and carbamazepine are all used to help to stabilize the moods to prevent the fluctuation between the highs and the lows. If someone is has a predominantly more of a depressed like state, then using SSRIs would be a first line drug. NDRIs and tricyclic antidepressants are also used. Again, some of the issues with that is it's affecting dopamine that might have some concerns with the manic episodes. And finally, with someone's really manic or really excited, they may use benzodiazepines to control the symptoms. So long-term use of lithium salts are the primary or the first-line therapy. Lithium, if you remember from your grade 10 chemistry class, it's located right below hydrogen and right above sodium and potassium. And so lithium is a positive ion that's very small. And why that's important to think about is when I'm looking at, we don't really know precisely what the mechanism is for this, but what I suspect is going on here is because the lithium ions are so small, yet they possess a positive charge, they probably go inside nerves, which are supposed to be more negatively charged, and they're not going to be affected by the cell membrane and some of these transporters because they're so tiny. So it may just infuse or diffuse inside the nerve cells, and just basically modulate the membrane potential of them. That's what I suspect is going on. Nobody really knows, but I think that's what's going on. Is they just sort of make it so that it sort of balances the charge voltage difference. Now, what's interesting, just as an aside, is that lithium. It used to be in 7-Up. I don't know why they would put it in there, but it was in 7-Up. I also found that I think when we were in Spain this summer, we were drinking soda water or mineral water, and one of the active ingredients they had in it was lithium salts, which I thought was weird. So it's supposed to have a bit of a calming effect, I guess. I don't know if that's something that you should be consuming on a daily basis. The biggest issue with lithium is because it's a salt, it's going to mess around with the organs involved with that sort of are affected by positive and negative ions. If you think about it, the main side effect is that it causes polyuria, so diabetes insipidus, because the lithium, the positive ion, it doesn't get reabsorbed by the kidneys because it's too small. So this added salt is just going to flow into the ureters and pull water with it. It's going to have an osmotic effect. So it's going to basically cause increase in urination, which is potentially going to lead to dehydration. Also, it appears to have some fine muscle tremors, which is associated with it. It can interfere with nerve firing in general, so you might get some of the side effects that you might see similar to some of the anti-epileptic drugs, like where people are suffering from fatigue, they might be a little bit confused, you get nystagmus, muscle weakness. The biggest concern with this is that there's going to be kidney damage can occur, and that's resulting from just the fact that you're taking a salt in that is upsetting the function of the kidneys. Another thing that can happen is it can go and mess around with and cause hypothyroidism, and that's related to, I guess, the fact something to do with iodine, I suspect. So lots of side effects with lithium, not something I would want to be on long term. It does stabilize moods, it works pretty well, but not lots of problems associated with it long term. Okay, we're almost done. So final movement disorder we're going to talk about is Parkinson's disease, and we've already discussed a little bit that basically Parkinson's is a result, degenerative disorders result in decrease in motor function that It's caused by low amounts of dopamine in the substantia nigra. And when it comes to Parkinson's disease, the main neurotransmitters that we target when we're trying to treat it is dopamine, but also acetylcholine has a secondary effect on muscle control in the body as well. Now, when it comes to clinical presentation, the four main things you see with Parkinson's is people have a resting tremor, as we mentioned before. If you go back to my pictures on dopamine, cause of muscle rigidity, so they kind of they're all tight and with a little bit of a tremor there. They have difficulties moving the muscles, and you'll see changes in the person's posture. So they'll start slumping over in a particular way. Secondary symptoms are related to low levels of dopamine. Think about dopamine involved with moods, concentration, a few other things. Low amounts of dopamine are going to cause people to feel depressed. It may impair cognition and cause people to become senile. And then finally, it may cause difficulties speaking, partly because of the effects that it has on the nervous system, but also related to the effects that it has on the muscles as well. So, when it comes to Parkinson, there's several different ways that drugs are developed to treat it. One way is you're going to try to replenish dopamine. Another way is you're going to try to target dopamine receptors. So we've got dopaminergic drugs, and the way that they work is, we'll talk about levodopa and carbidopa in a second. It's primarily trying to supplement with the precursors for dopamine so that you can make more dopamine in the central nervous system. You could have drugs that basically target the dopamine receptors directly, or take drugs like MAO inhibitors and catechol-methyltransferase inhibitors that are involved with the inactivation of dopamine. So if you block those drugs, hopefully you'll elevate dopamine levels in the central nervous system where it's needed. Anticholinergics have a secondary role. It's not a primary thing, but it can kind of help a little bit as an add-on drug, as an adjunctive therapy. Amantadine is another drug that used to be used for influenza, has possibly some beneficial effects just for some weird off-label indications for it. Now remember when we're talking about phenylalanine gets converted to tyrosine, and then tyrosine gets converted to levodopa in the body. Now, L-dopa or levodopa, it's been used as a drug to help treat Parkinson's. It's one of the first-line therapies for that. Now, I'm showing you this picture because there's a few things that I want to emphasize here. Is that levodopa, the biggest issue with it is that it's fairly easily inactivated. It can be inactivated in the periphery, but what happens is there's an enzyme that converts levodopa to dopamine outside of the central nervous system. And what ends up happening is if this occurs, levodopa will be transported into the central nervous system, but dopamine cannot be transported, cannot cross the blood-brain barrier. And so one of the issues with that, maybe I better start over. Definitely getting tired by the end of the day here. Levodopa, when it gets converted to dopamine outside the central nervous system, it's going to be easily broken down by catechol-methyltransferase and MAO inhibitors. So if it gets broken down, it's never really going to get an opportunity to cross the blood-brain barrier and have its desired effect. Now, what's interesting, there's another drug called carbidopa. Carbidopa inhibits the enzyme, I can't remember the full name of it, but basically inhibits the conversion of levodopa for L-dopa to dopamine in the periphery. Now, carbidopa doesn't cross into the blood-brain barrier, so what it does is, in the periphery, it inhibits the conversion of L-dopa to dopamine so that more L-dopa goes into the brain or into the central nervous system so that it's more bioavailable or more available to do its job there. If you didn't take L-dopa with carbidopa, then most of it would be converted to dopamine outside and it would never have its desired effect in the brain. And that would mean you'd have more side effects with less benefits. So, if you want to elevate dopamine levels in the central nervous system, you take levodopa, and to get an even better response, you combine it with the carbidopa. So that's one target for increasing dopamine levels. The other target is to inhibit the enzymes that are responsible for breaking down L-dopa and dopamine, and that's the catechol-methyltransferase and the now inhibit monoamine oxidase enzymes. So take inhibitors for those two, that'll also elevate dopamine levels. And then the other way you can do it is you target the dopamine receptors using dopamine agonists. And this drug that's shown on the right there is derived originally from ergot, and it's used to target the dopamine receptors and have an effect that way. And then finally, the anticholinergics have an effect. So this is like a little pictorial representation of how to target receptors for Parkinson's. So L-dopa and carbidopa, these are given in combination, as we mentioned before. Dopamine does not cross the blood-brain barrier, and levodopa does cross it. So levodopa gets converted to dopamine using aromatic amino acid decarboxylase enzyme in the presence of vitamin B6. And if you combine it with carbidopa, carbidopa will inhibit that enzyme, and as I mentioned before, it does not cross the blood-brain barrier, so that means it prevents the production of dopamine outside the brain so that more L-dopa can go into the central nervous system and be produced there. So the combination has a synergistic effect, and I think I've stressed this point enough. So L-dopa and carbidopa are given simultaneously, and that's kind of the first-line therapy when treating Parkinson's. The side effects associated with this is going to be, if you remember back to the diagram we had of the dopamine, it's going to be associated with the effects of elevated dopamine in the system. So nausea and digestive disturbances are not uncommon. It can cause low blood pressure. It can also cause in high amounts hallucinations. It can stimulate the cardiovascular system. It can even cause excess libido, which might be welcome in a 70-year-old man, but there are reports. I remember reading some lawsuit of some man who was on Parkinson's medication, and he got himself into trouble at the old age home, and he pleaded not guilty, and that's just a side effect of the medications he was on for his Parkinson's. So I don't know what happened with that case, but it was kind of a humorous case. So the other thing that can happen if you have too much dopamine, it can cause the choreas or the dyskinesias, so involuntary movements. So not enough dopamine, you get the resting tremor. Too much dopamine, you have these involuntary spastic movements of the limbs. Some other things to be aware of, it's drug interactions. So you don't want to take anticholinergics, it'll decrease the effects of L-dopa. Avoid monoamine oxidase inhibitors unless a specialist is recommending it, because it can elevate dopamine levels even higher. Iron will decrease the absorption of L-dopa. Protein can also affect the absorption of L-dopa because these are amino acid-like structures, compounds. Another thing you can do is with Parkinson's is you can, instead of supplementing with dopamine, is you give a drug that crosses the blood-brain barrier that will bind directly to those dopamine receptors. And so there's a couple different classes. There are ergot derivatives, so this is the same group of compounds that are very similar to what you get from the ergot fungus. So ergot derivatives like bromocriptine, and there's non-ergot compounds that are structurally unrelated. Both are indicated for Parkinson's disease, and they bind to receptors within the corpus striatum. Side effects are going to be similar to what we saw before. Watch out for people who have ergot allergies, and some people have those, wouldn't respond to it. If people have renal failure, then the drugs won't be cleared as quickly, so you may have to adjust the dosage for it. And then the side effects, a little bit similar to the L-dopa. You have low blood pressure, you get hallucinations, confusions, nausea, issues with movement, so the dyskinesia, leg cramps, and then sometimes people will just suddenly pass out, and that's one of the side effects with it. A couple other quick things. Catechol-methyltransferase enzyme. If you remember, this enzyme inactivates epinephrine, norepinephrine, and dopamine. and it uses S-adenzylmethionine as a cofactor for it. So the strategy is if you were able to block this enzyme, then it might help to elevate dopamine levels in the body. And this will help to prolong the response of the L-DOPA. So it helps sort of work synergistically with the other ones. It wouldn't be a primary first-line drug. It would be used as an adjunctive drug for that. Side effects, you can read there. Some digestive issues, changes in urination, a few things. The MAO inhibitors, if you remember, monoamine oxidase enzyme targets epinephrine, norepinephrine, serotonin, dopamine. So the MAO-A1 targets all those. The monoamine oxidase B enzyme has affinity for dopamine almost exclusively. So they've created drugs that target the MAO-B enzyme, and this will kind of have a positive effect to amplify or to enhance the effects of the L-DOPA. Side effects mostly can cause increased stimulation and some digestive issues. Finally, anticholinergics, as I mentioned before, acetylcholine has a bit of an effect on the resting tremor. It's a secondary neurotransmitter involved with movement. It's not the primary one, so some anticholinergic drugs might be used as an adjunctive or an add-on treatment for Parkinson's. Beyond that, you can read the rest of the slide. Finally, amantadine. It's an antiviral drug used for influenza. It's also used for Parkinson's. It's kind of a weird indication for it. We don't really know how it works. It appears to stimulate the release of dopamine and may block some glutamate receptors and also reduce acetylcholine. So it's more going to act as a secondary effect. There's a few little side effects you can read there. It's not a very important drug, but I'm just including it anyways. Okay, so Parkinson's, we got one more slide we'll go through and that'll be it. So Parkinson's is a result of low levels or insufficient amounts of dopamine. Huntington's chorea or other movement disorders where people have these uncontrolled movements of their bodies, they usually result possibly from like an excess release of some neurotransmitters. So what happens here is you have low acetylcholine levels and GABA levels. Dopamine levels remain relatively normal though. So some of the drugs that are used to treat this are basically drugs that block dopamine to have that sort of positive effect there. Barbiturates were used in the past, but there are too many side effects associated with it. And it's more to just keep these people sedated. Beyond that, that's about all you can read this on your own. So there we are. We're having a slow connection. Hopefully the recording went okay. So I think that's it for now. If you guys have any questions, ask Dr. Legg what is going to be on the exam, and then we can ensure to be able to help. Maybe I created some exam questions for in the past. I'm not sure if she'll be using them or not. But discuss with her what you guys need to know for the exam. Anyways, I hope you guys are well, and it's been a pleasure teaching you again, and we will see you around at school, okay? All the best, you guys. Take care.